Hello, today we're going to have a sit-down talk about multiple myeloma. I'm going to tell you everything you need to know about multiple myeloma with the exception of the treatment. Unfortunately, we don't have enough time for me to dwell into the treatment because there are so many new drugs and so many new treatments in that area that it would just not be possible. We would need at least 3 hours to discuss the treatment. So in this video, we'll look at those factors that you would need to know to better understand your condition and to understand myeloma. First of all, what is multiple myeloma? Multiple myeloma is a blood cancer that is sometimes classified as the second or third most common blood cancer in the United States, depending on which source you check. But even with that designation, multiple myeloma is still less than 1% of all the cancers in this country. It is estimated about 35,000 people every year will be diagnosed with multiple myeloma. Now, multiple myeloma derives from a white blood cell, the B lymphocyte, which is transformed into what is called a plasma cell, which is the cell that makes immunoglobulins. Immunoglobulins, as we know, take part in the adaptive response, immune response, in that they attach to bacteria and they attach to viruses and other alien germs that enter the body, and they facilitate phagocytosis and the destruction of these invading germs. So that immunoglobulins normally play a very important role and they are very beneficial to our bodies and to our health. But in the case of multiple myeloma, the plasma cells differentiate into a single clone. Well, one particular clone of plasma cells proliferates uninhibitedly. And in the process of this proliferation, these plasma cells produce proteins, immunoglobulins, that build up in the blood. And this is what we call multiple myeloma. For some unknown reason, multiple myeloma is more common in men than in women, and in black people than in white people. Now, what is the cause of multiple myeloma? Well, it remains an enigma at this point. There are theories that propose that multiple myeloma occurs more frequently in people who are exposed to benzene and to organic solvents and to radiation and to other chemicals in the environment. But at the same time, there are many patients who have multiple myeloma and who never were exposed to any of these chemicals. In about 90% of all myeloma patients, there are chromosomal abnormalities to be found. Now, these are different chromosomal abnormalities, different chromosomal changes that we can find in the cells of the myeloma strain of plasma cells that are proliferating in the bone marrow. And these include what are known as trisomies, or it's a duplication of one of the chromosomes leading to 3 of a single chromosome. It's called trisomy. Or they can be deletions, frank deletions of portions of the chromosome. Or they may be what we call translocations, which are transferal of genetic material from one chromosome to another. The double-stranded DNA in the chromosome actually breaks and is translocated to another chromosome where it attaches itself. And for example, there might be the transfer of material from chromosome 4 to chromosome 14. Most of these genetic aberrations involve the chromosome 14, more specifically the immune globulin H or heavy chain locus that codes for the heavy chain of the immune globulin. Immune globulins have both a heavy chain and a light chain, and they have two of each of these, two heavy chains and two light chains, so that in multiple myeloma, we would only expect to find one particular light chain. The light chains are designated either kappa or lambda light chains. So that if you have a particular strain clone of cells proliferating, then they would be making only one single kappa chain or light chain or lambda chain. And this is what we would find on analysis of the immunoglobulins in the blood. These genetic alterations that can be found in the plasma cells that are proliferating in the bone marrow have prognostic value because in the presence of certain particular translocations or deletions, we can predict how the disease will behave. And we can therefore use this for prognostication and for risk stratification of patients. And through that, doctors can determine how aggressive to be in the treatment of multiple myeloma. For example, the deletion of 17p or the translocation of 4 to 14 or the translocation of 14 to 16 or 14 to 20, these are genetic alterations that have a less favorable prognosis. The translocation 1114 or the presence of trisomy tends to have a more favorable prognosis in patients with multiple myeloma. Multiple myeloma is not an isolated disease. It is believed that it is part of a continuum of plasma cell disorders, which start with MGUS, or monoclonal gammopathy of undetermined significance. So MGUS is characterized by less than 10% plasma cells in the biopsy specimen from the bone marrow, as well as the total spike protein, M protein level below 3 grams per deciliter. These patients are generally asymptomatic. Now, MGUS can progress to Waldenstrom's macroglobulinemia or to multiple myeloma or to amyloidosis at a rate of 1% per year. But what is this M protein? What does M protein mean? M protein is the monoclonal protein that is produced by the plasma cells, the immune globulins that these plasma cells are producing. Because they're producing these cells in an uncontrolled fashion, we have a build-up of these proteins among all the other proteins in the blood. And when we measure the proteins in the blood, we find that there's a spike. There is a particular band of protein that is excessively high. And this is known as the M protein, which, as we discussed before, are immunoglobulins produced by the plasma cells. And by measuring the kappa or lambda levels, we can determine what is known as the free light chain ratio, which is a prognostic factor and which is also used as a diagnostic factor, as we will see later in this discussion. Over time, MGUS can progress to what is known as smoldering myeloma. And smoldering myeloma is a form of myeloma in which the bone marrow biopsy contains between 10 to 60% of clonal plasma cells. And the protein, the M protein level, can be above 3 grams per deciliter. But at the same time, these patients are asymptomatic. They do not have the end organ damage or any of the typical myeloma defining events that define multiple myeloma. And smoldering myeloma is a part of the continuum that I mentioned earlier, in that smoldering myeloma can progress to multiple myeloma over the years. In fact, over the first 5 years, smoldering myeloma will progress to multiple myeloma at a rate of about 10% per year. And in the second 5 years after that, it usually would progress at a rate of 3%, and thereafter at a rate of 1.5%. So we can expect that 1.5% of patients with smoldering myeloma after 10 years will continue to develop multiple myeloma. So what other types of myeloma are there? Well, some patients with multiple myeloma do not secrete the M protein. And when doctors run a serum protein electrophoresis, which is a test to look for this M protein, even though a patient may have myeloma, we still end up with a test result that says there is no M protein, there is no production of these immunoglobulins, the proteins that cause the M protein spike. And therefore, it can mislead and it can cause the misdiagnosis unless we are aware that certain types of myeloma can present in this fashion. These are what we call the non-secreting myelomas. Now, the non-secreting myelomas can be further divided into producing and non-producing myelomas. Producing non-secreting myelomas are myelomas that produce immunoglobulins but are not able to secrete the immunoglobulins into the blood, into the circulation. And on the other hand, we have, of course, the non-producing, non-secreting multiple myelomas that do not produce immunoglobulins, period. And this is a separate class, a different class of multiple myeloma. What this all boils down to is that the lack of an M protein spike on serum protein electrophoresis does not rule out the existence of a multiple myeloma. How do we diagnose multiple myeloma? In order for us to make a diagnosis of myeloma, we need to have 10% plasma cells on the bone marrow biopsy, or we have to have a biopsy-proven presence of plasmacytoma, which is a tumor, a growth of plasma cells that when we take a biopsy, we can confirm that this is in fact what we have. And if we have that, or we have 10% plasma cells, in addition to one of the following criteria, then we can diagnose a patient with multiple myeloma. Now, these criteria that we use to diagnose multiple myeloma are called myeloma-defining events, and they include the original CRAB criteria. The CRAB criteria were criteria that were used in the older classification, the older diagnostic system, but that we have extended to the revised diagnostic criteria. And any one of these CRAB criteria in the presence of the biopsy with 10% plasma cells, or the presence of biopsy-proven plasmacytoma, will confirm a diagnosis of multiple myeloma. Now, what does this CRAB acronym stand for in the CRAB criteria? C stands for calcium. The serum calcium must be below 11 milligrams per deciliter. If it is above that, this is what we call elevated serum calcium or hypercalcemia. And this would qualify a patient as having multiple myeloma in the presence of those aforementioned conditions. The second letter in the acronym CRAB is the R, and this is the renal which is a word that we use to describe the kidney in medical terminology. And the kidney function is also used as one of the criteria for the diagnosis of multiple myeloma, in that a glomerular filtration rate, which is the rate at which the kidney is clearing the body of toxins, creatinine, if that level is below 40 ml per minute, then that patient is considered as having renal failure and is therefore classified as having multiple myeloma in the presence of the aforementioned conditions. The third letter is the A, or anemia. So if the hemoglobin level is below 10 grams per deciliter, then that is classified as anemia and would also permit a diagnosis of multiple myeloma. The final one is the bony lesions, which is the B in the CRAB acronym, and B stands for bone and represents the lytic lesions, these punch out lesions that we find on the skeleton of patients with multiple myeloma. And once these are present, then, and we have the 10% plasma cell presence or biopsy confirmed plasmacytoma, then we can diagnose a patient with multiple myeloma. So the most recent additions to this system of diagnosis are the biologic markers that have been included, in that these biologic markers, if they're present in the presence of the 10% of plasma cells on bone marrow biopsy or a biopsy confirmed plasmacytoma, then that would confirm a diagnosis of multiple myeloma in patients. So what are these biological markers that were added? The first one is a 60% rate of plasma cells in the biopsy specimen, bone marrow biopsy specimen. If that is there, this would confirm the diagnosis in the presence of the aforementioned condition. The second one is the ratio of involved free light chains to the uninvolved free light chains. And if that ratio is greater than 100, then that too would confirm a diagnosis of multiple myeloma. Now, what does involved light chain mean? Involved light chain means that that is the light chain that is being produced by the proliferating plasma cells in the bone marrow. So that if it's the kappa, we would divide the level of the kappa light chain by the level of the lambda light chain, and that if that ratio is above 100, then we can confirm a diagnosis of multiple myeloma. It's important to note that for this to be utilized, the total level of the free light chain, the involved free light chain, must be over 100 milligrams per liter. The third biologic marker that is used in the diagnosis of multiple myeloma is the presence of lesions on an MRI. And if these lesions are of a diameter greater than 5 millimeters, then we can utilize that as one of the criteria for diagnosing multiple myeloma. It is important to note that these lesions do not have to be lytic lesions on the MRI. Why is this important? It's important because the MRI can pick up lesions in the bone marrow before the development of lytic lesions in the skeleton, and therefore it would provide for earlier diagnosis and early initiation of treatment. So what are the symptoms of multiple myeloma? Well, multiple myeloma can sometimes present with no symptoms at all, and patients in such situations are diagnosed on incidental findings on their routine lab work. For example, they may come in to have an annual physical and find that their serum calcium is high, or their hemoglobin is low, or they may present for a regular checkup and find out that their kidneys are failing or that their protein is high. So sometimes it can be asymptomatic and these changes are discovered incidentally. Patients can also suffer pain. They can have nonspecific pain, for instance, pain in the rib cage or pain in the spinal column. And the pain is usually the result of osteolytic, these punch out lesions in the bones of these patients that are resulting from the activation, the stimulation of osteoclasts, which are cells in the bones, in the bone marrow, and on the surface of the bones that are active in resorbing the old bone. And by resorbing the old bone, and due to the fact that there's also a concurrent suppression of the osteoblasts or cells that build up bone, this leads to these lytic lesions or punch holes that we see on x-rays and CAT scans of the skeleton of patients with multiple myeloma. They may also have nonspecific fatigue and weakness, or they may have the high calcium levels, as I mentioned before, and high calcium levels are the result of the same osteolytic lesions that were described earlier, in that as the osteoclasts resorb the bone, they release calcium into the circulation, and this calcium builds up, leading to high calcium levels or what is known as hypercalcemia. Of course, hypercalcemia itself can cause certain symptoms. It may cause fatigue and tiredness. It may cause a clouding of the sensorium, or it may cause weakness and frequent urination and constipation. And very high levels of calcium may even cause coma. This same osteoclastic absorption, hyperabsorption of the bone, leads to weakness of the bones. And as a result, patients with multiple myeloma can suffer fractures with the minimal amount of trauma. And these are called pathological fractures and may be the presenting symptom in patients with multiple myeloma. The anemia that we see frequently in patients with multiple myeloma is the result of the crowding out of the red blood cell precursors in the bone marrow by the expanding plasma cells. This same process can affect the precursors of the platelets in the blood, known as the megakaryocytes. They can be crowded out as well, and this can lead to a low platelet count or thrombocytopenia, with all the resultant symptoms and consequences, bleeding and bruising, etc. Patients with multiple myeloma may experience frequent infections, and this is believed to be the result of a process known as immunoparesis, in which the abnormally produced immunoglobulins suppress the production of the polyclonal immunoglobulins that are needed for our protection. And patients with multiple myeloma who have immunoparesis suffer from frequent infections, especially from encapsulated bacteria such as Streptococcus pneumoniae and Haemophilus influenzae. So what diagnostic tests do we do when a patient is diagnosed with multiple myeloma? For starters, a complete blood count will be done, known as a CBC. And on that test, doctors can evaluate the level of the hemoglobin, and they can evaluate the level of the thrombocytes, the platelets, to see if the patient has anemia or thrombocytopenia, a low platelet count. They will also do a complete metabolic panel. And on this study, they can evaluate the kidney function. They can evaluate the level of the LDH, which is a prognostic factor. They can evaluate the level of the serum calcium, which, as we mentioned before, is important. They can evaluate the level of albumin, which also is a prognostic factor, in that low albumin levels tend to predict a worse prognosis. A serum protein electrophoresis, or SPEP, should then be performed. And on this test, a test is run to see which band of protein is elevated in the blood of a patient with multiple myeloma. And that band, if it is the gamma globulin band, is then evaluated by an immunofixation test, which will single out that particular immunoglobulin that is elevated in the blood. And we would therefore be able to have a clearer picture of what type of multiple myeloma we're dealing with. These same tests can also be performed on a urine, and a 24-hour urine study would be done to evaluate the function of the kidney, and at the same time, a urine protein electrophoresis and a urine immunofixation test would determine the proteins and the immunoglobulins that are being excreted in the urine of that patient. The light chains that are found in the urine are referred to as Bence Jones proteins after the name of the physician who discovered them. A bone marrow biopsy would also be performed, which would give us information on the percentage of plasma cells in the bone marrow, as well as provide material for performance of a genetic evaluation of the cells. This is most popularly done with a FISH evaluation, which stands for fluorescent in situ hybridization evaluation. This is a test that seeks out certain genetic alterations in the chromosomes of the plasma cells involved. Your doctor may also want to do a beta-2 microglobulin evaluation, because beta-2 microglobulin, as we will see later, is a prognostic factor in multiple myeloma. We'd also want to do a skeletal survey. And in the past, we used plain film x-rays, but today it is recommended that we use CAT scans, or we use PET CTs, or we use MRIs. The most popular type of CAT scan today for evaluation of myeloma patients is the whole body low dose CAT scan. Finally, a free light chain assay will be performed. And a free light chain assay will help with the diagnosis, as was mentioned earlier before. And in some patients with non-secreting multiple myeloma, the free light chain assay is positive, or we can find elevated free light chains in those patients, meaning that in such cases, these patients are not producing the M protein, but they're producing either a kappa light chain or a lambda light chain. So how is myeloma staged? Multiple myeloma is staged based on the International Staging System, which is a system based on the presence of any genetic alterations. It is based on the LDH level, the serum albumin level, and the serum beta-2 microglobulin level. In stage 1, the serum beta-2 microglobulin level is less than 3.5 milligrams per liter, and the serum albumin level is greater than 3.5 grams per deciliter. In stage 3, the serum beta-2 microglobulin level is greater than 5.5 milligrams per liter. Any patient who does not fall into stage 1 or into stage 3 is classified as stage 2. So why is staging of multiple myeloma important? It's important because it helps with the prognosis, it helps with risk stratification, and therefore it helps with the choice of the most appropriate approach to management and treatment. I hope I was able to answer most of your questions regarding multiple myeloma. If you have any further questions, do not hesitate to write your questions in the box below, and I'll respond to them. Until the next video, stay healthy and stay safe.